I'm the Director of Workforce Development for TEPHI, the Texas Epidemic Public Health Institute, which is sponsoring these grand rounds. And all right, so let's get started. Topic of big interest today. Let me introduce Dr. McLellan. We are so delighted to have her with us. She is a professor in the Infectious Disease Division at the UTMB. He's medical director of the Biocontainment Treatment Unit, director of biosafety for research-related infectious pathogens, and director of the Special Pathogens Excellence in Clinical Treatment Readiness and Education Program. So in her spare time, maybe she sleeps, I don't know. After training in internal medicine, pediatrics, and infectious diseases, she returned to Tulane, where she held joint appointments in the School of Medicine and the School of Public Health and Tropical Medicine, and then was recruited to UTMB in 2018. She has over 25 years of experience in medical and public health education and in clinical care of and public health response to emerging infectious diseases. She's participated in outbreak and disaster response in various resource-poor settings, including as a clinical consultant for WHO during the West Africa and Democratic Republic of Congo Ebola outbreaks, providing direct care as well as assessment of treatment units and support of clinical trials for medical therapies. In her position at UTMB, her focus is on improving the clinical care of individuals infected with high containment pathogens, both in high and low resource settings, and in developing programs for integrated response to pandemic threats, including the rapid scale-up of research during outbreaks. So I'm going to stop sharing my screen so you can, and welcome Dr. McLellan.
All right, thank you. Can everybody hear me okay? Somebody say yes.
Yeah, there we go. Oh, I forgot to say, put your questions in the chat. We will give them to Dr. McLellan after her talk.
Okay, so now again, the WebEx is not my.
Yeah, so down at the bottom, there should be a share.
Yeah, I see it, and I think we're good. Does that give everybody?
Yes, we see it.
Okay, excellent. All right, well, thank you all very much for inviting me to give this grand rounds. It's really very much my pleasure. So I'm clinician is the important thing for people to know. So there's definitely going to be some clinical here, as well as the public healthy part. And hopefully, if you do put questions in the chat, I'm going to try and set it up so that I can see them. Not sure if I can do that from where I am, but at any rate, so I'm perfectly happy to try to answer questions as best I can on whatever things as they come up. So disclosures, I have nothing to disclose in terms of financial stuff. I will discuss some experimental or non-approved therapies because that's most of what there are. And there are graphic pictures of lesions and genitalia in this presentation. I will try to remember to warn you, and I cut some of the worst ones out for this audience, but just be aware. So a little bit about monkeypox in general. So this is a disease that was first isolated from macaques in 1958. These were actually research macaques that were in Denmark for research. They and this happened to be noticed that they had something, and they figured out that they had this pox virus. But in fact, monkeys, despite the name, are not likely the natural reservoir. We believe that certain types of rodents are, and the exact best reservoir we don't know, nor do we know if there are animal reservoirs who do not become symptomatic from the disease. It was recognized as a human disease in the Democratic Republic of the Congo in 1970. And over the next couple of decades, a number of cases were identified in Western African countries, as well as many more cases reported from the Congo Basin countries. And it became apparent that the West Africa cases seemed to be less severe, with less evidence of human-to-human transmission, and a relatively lower case fatality rate, reported as 1 to 4%. Initially, most people now say 1% or less. But the Congo Basin cases had about a 10% case fatality rate, so it's appearing to be a slightly different disease. And over the subsequent decades, again, increasingly recognized, especially in the Congo Basin. And then there's been a large outbreak first reported in Nigeria in 2017. In your top right corner, you'll notice that there's plenty of other pox species that can cause human infections. And that's important because, of course, smallpox is the main human one that we have thought about historically, for which humans are the reservoir and the primary carriers. But our vaccines are made from cowpox virus. Now, monkeypox in Africa, as I mentioned, only relatively rare cases confirmed until relatively recently. The DRC, however, has been reporting greater than 1,000 suspect cases for years. It's about 2005. And it's been then increasing in distribution number since 2016, and a lot of that associated with this large Nigerian outbreak. Now, that is a West African clade, as opposed to the Congo Basin clade, which is what is seen primarily in the Democratic Republic of Congo. Now, in this recent Nigerian outbreak, it was started to recognize that there were some severe cases and some HIV associated and some human-to-human transmission. We're going to get back to that in a moment. So here is an article that describes sort of tried to look at what are the whys of this acute Nigerian outbreak, what was going on. And they point out the last previous confirmed case in Nigeria had been 1978. Molecular data, looking at the different strains, suggested multiple introductions into humans. And they said this seems to be more than just the end of smallpox immunization. So what do we mean by that? What we mean by that is, as I mentioned, that we use cowpox to immunize against smallpox. Well, it looks like cowpox immunizes against monkeypox. And people had been vaccinated previously against smallpox. Worldwide, that stopped in 1980. And so younger individuals did not have that immunity against poxvirus diseases, including monkeypox. So that's one reason for the emergence of it. But they proposed a number of other issues, including more human encroachment onto wild areas, conflicts, deforestation, the use of rodents for food. And why do they keep saying that? Because most cases were thought to be, especially of West African clade, primarily related to contact with animals rather than human-to-human transmission, and specifically rodents. Now, outside of Africa, what kind of outbreaks have we had? Well, the big one was in the United States in 2003, and this was associated with imported Ghanaian rats. That's that cute little guy in the upper right corner there. So some people like to have these kind of critters as pets, and so they end up in pet stores. And it turns out some people also like to have prairie dogs as pets, and they end up in pet stores. And when you put them next to an infected Ghanaian rat, they can get smallpox. And so there ended up being 47 confirmed cases in the United States associated with ownership of these rodents, primarily prairie dogs, as pets. 72 if you add in suspected as well. No human-to-human transmission was documented in this outbreak, and there were no fatalities. But it did solidify recognition of two clades, because a number of experiments were done with comparing this virus with strains of the Congo Basin strains. And in animal studies, including both rodent studies and non-human primates, they really showed much higher virulence of the Congo Basin strains, including much more of a predilection to go to visceral organs, by which we mean, for example, the GI tract or the lungs or even the brain, which was not really seen so much with the West African strain, which kind of sticks to the skin and the lymphatics. Now, after that, there were a few more imported cases coming, all imported from Africa, 5 in the UK, 2 in the US, Singapore, 1, Israel, 1. Amongst all of these cases, there was no transmission among people on the airplanes. Realize these people were all on airplanes while they had it or while they were incubating it, and it was recognized when in the country to which it was imported. There was 1 healthcare worker transmission and 2 family transmissions. Now, a big case that was in the US last year was a traveler from Nigeria. And this individual had a pretty severe disease with a 32-day hospital stay. This is all published data out of NNWR. And there were 223 monitored contacts from the airplane, from healthcare workers, from laboratory workers before it was identified what he had, family contacts. None were considered to be high risk by CDC estimation, but 34 intermediate risk contacts were offered the, at that time, available vaccine, which was ACAM 2000. Nobody accepted it, and you'll see why when I talk about vaccines. There were no secondary cases, however. There was an additional US case later on in 2021, which was also a traveler from Nigeria, but for which there's not published information. Now, what about this time? Well, as you know, last week, WHO declared the monkeypox spread a global health emergency. And you see that says 16,000 cases in 75 countries. And also this mentioned that is overwhelmingly among men who have sex with men. So a little bit more about this latest epidemiology. Every time I give this talk, I've got to run and update the numbers. So you can see that last week it said something about 16,000 cases. So as of yesterday, 25,000 cases in 76 non-endemic countries. So a week ago, that was 70 non-endemic countries and 75 and 5 endemic countries. But just talking about the non-endemic countries, we're now up to 76. A lot of sort of rapid appearance in multiple countries, especially the original ones in Europe, suggest that there'd actually been more than a single point introduction. So this wasn't one individual resulting in a lot of spread. It was probably more than one individual resulting in spread, much of which had gone undetected. Texas is now up to 485 cases. By the way, that's doubled in the last week. And there is, as mentioned, a high association with people in the category of men who have sex with men, including bisexuals, trans, and so on. And some of these first cases were associated with Pride Month festivals, and so that kind of epidemiology was recognized relatively early. Now, what does that mean? Is this really a sexually transmitted disease? That's not really clear. And when we say sexually transmitted, that's sort of picking apart the difference between a pathogen which specifically utilizes the sort of characteristics of the reproductive system in terms of semen, vaginal fluids, et cetera, and so on to maximize transmission versus a pathogen which likes to go from one person to another through close contact. And let's face it, during sex, there tends to be a lot of close contact. So some interesting questions about that, and those remain not completely resolved, but we'll get back to a little bit later. Now, most definitely, it was noted that there were a lot of atypical presentations. It was also noted that most of these were mild cases. This slide a week ago said no deaths in non-endemic countries. It doesn't anymore. We have at least 5 deaths in non-endemic countries now. There's not a lot of details available about the clinical situation there, but encephalitis was mentioned among a couple of them, and immune compromise was mentioned for at least one of them. And so that gives us some hints that aren't really, at least the immune compromise isn't too surprising. But overall, this is a really difficult outbreak to deal with from a public health standpoint. It is very difficult to do contact tracing amongst individuals who are having multiple sexual contacts, especially if it's a network where people aren't necessarily identifying themselves in some of the settings in which these contacts occur. So very personal nature of these exposures. The other thing is that mild cases may not be recognized by the individual who has them. So they may not even recognize that they may be transmitting something during an encounter. So this is a nice map. You can go on Wikipedia. I haven't updated it in a little bit. So there's probably a few more red countries. Basically, those red countries indicate the countries for which no clades of monkeypox had been previously identified. So in the US, we are now up to a total of 6,326. Texas is up to 485, as I said, doubling. Dallas is ahead of the Houston region. That's Public Health Region 2-3 includes Dallas. Public Health Region 6-5S includes Houston. And you can see we're trying to catch up. Now, what was monkeypox before this outbreak, or how was it described? And then we'll talk about how it's being described now. So the classical description of transmission is contact with infected lesions or fluids, including old scabs from skin lesions. Also contaminated bedding or clothing that somebody has used. Respiratory droplets. Well, unlike smallpox, which was very clearly easily transmitted with respiratory droplets and aerosols, that doesn't seem to happen all that easily with monkeypox. It seems to require prolonged face-to-face contact. Human to human, as I said, more with Congo Basin, less with West African, having been described in the past. Animal to human, absolutely described, especially considered the major means of transmission in the past for West African clade. What about human to animal? Well, we don't know about that yet, but that is something that we worry about. And again, I'll come back to that again later. Now, again, the classical sort of description and differential diagnosis for those of you of a clinical bent. If you open most textbooks that have something about monkeypox, this is what it will tell you. Incubation period 5 to 15 days, up to 21. A prodrome, just sort of a flu-like prodrome of feeling crummy, having fever and fatigue, sore throat and cough may be present. A lot of adenopathy, that's always pointed out as being more so than smallpox. And then a skin rash that appears 1 to 3 days after the fever that starts with macules, in other words, basically red spots that become papules, in other words, red bumpy spots, vesicles, which means little blisters, and then pustules, which means a blister with pus in it. These umbilicate, which means they sort of dimple down into the middle and then slowly dry up and become scabs. The distribution is classically described as appearing first in the mouth or face, then going to the extremities, and then going to the trunk. It also can be seen on the soles and the palms, which is relatively unusual for a lot of rashes. It is described as tender or pruritic in many cases. And again, historically, same stage of development. In other words, you don't have some that are just starting and some that are fully developed. Deep-seated, what does that mean? Well, for those who've had chicken pox, those are sort of very superficial in the skin layer, and it's easy to pop them or scrape them. True of herpes as well. But these lesions are deeper in the skin so that they have a pretty strong covering of skin over them, which means they feel rubbery to somebody who touches them, as opposed to feeling like a very thin-walled blister. This process evolves over 3 to 4 weeks before it goes through all that process and all these scabs fall off. And throughout that time, the individual is infectious and the material from their skin and the scabs is infectious as well. So here's a couple of pictures from prior to this outbreak showing the sort of a progression of some of these lesions. You can see top left, if you can see my pointer, this really looks more like a tiny little vesicle, and then it starts looking like a little boil, and then it gets to be on some red around it, and then it starts to scab over, etc., right? And these were a couple of these other two were photos from the 2003 outbreak in the US, and shows lesions on a child with that sort of red base and a young man who liked prairie dogs. But what were we seeing in 2017? And this is kind of interesting because it didn't really get to, I suppose, a really attention-grabbing recognition among a large population that this was different. I should say a large population of the medical community, that this looked a little different. So there's a number of reports, if you go back and hunt and look, many of them which include the first author of this report, Dr. Ogoina. But this particular one is about 51 hospitalized cases that were reviewed, or 40 out of them. It did include a child, an infant. It did include a woman who lost pregnancy and so on, but, and not on this slide, It was 75, 80 so percent male. Many of them, most of them had a facial rash, but a large proportion, 67%, had a genital rash. And this was different than how it had been described before, because previously the description was children and this overall rash, and children because thought that they were more likely to come in contact one, not to be immunized about smallpox in the past, but also to come in contact with the rodent vectors potentially. The other big thing is that a large proportion were HIV positive. All of the HIV positive were noted to have a genital rash, and also they easily had bacterial superinfections, and they had a longer disease and greater extent of rash. Okay, I think this is my first icky picture warning, so if you don't like icky pictures of clinical disease, close your eyes. So this is some of the pictures of the individuals described in that report, and you can see quite severe rash, quite significant genital involvement, also unfortunately quite disseminated in the neonate who did not survive, but also a couple of lesions on the bottom that are really kind of not so impressive and maybe kind of easy to miss if you weren't really looking. But this same author reported in a different report there, noticing that a lot of these cases were young adults in their reproductive age with genital ulcers, as well as other sexually transmitted infections. And it mentions, although the role of sexual transmission is not established, it's plausible in some of these patients. So what that really seems to mean is that this virus had jumped into a new efficient means of transmission and in being passed human to human during sexual activity. And in particular, if it was sexual activity with individuals who are having multiple partners, and you can see that that might be a really nice way to transfer infectious material onto mucous membranes, which are probably more likely to result in infections. So what's the current clinical presentation? I told you it was a little bit different. So a couple of things that are described: minimal prodrome or none, or lesions show up before the prodrome. A lot of genital and perianal lesions, as discussed with the Nigerian cases. Proctitis, a number of men who probably received their infection through receptive anal intercourse, presenting with perirectal pain and tenesmus. In other words, the urge to defecate when you don't really have anything in there. Fewer lesions in some cases, but pretty much if you look hard enough, you will find them. So for example, individuals who presented with rectal pain might not realize that they had lesions, but if you look closely enough around, you're going to find them. However, there may be just a couple, one on the leg and another one on the neck, for example, in somebody who has mild disease. It may not be a diffuse rash as was previously considered to be typical. Also, a lot of these lesions have been reported to be smaller than what's classically described. In other words, maybe half a centimeter instead of close to a centimeter. And very interestingly, some in varying stages. Whether that means inoculation at slightly different times on different parts of the body is unclear. Now, in general, it's described as relatively few requiring hospitalization. But in fact, there's a lot of pain control issues with this, and I'm going to get back to that later when I talk about care of the patients. Again, in this outbreak, definitely predominantly male, and the group being most affected right now is men who have sex with men and who have had recent new sexual encounters. But it has to be repeated over and over that anyone can get this. This is a disease that most of its known human history has not been transmitted primarily through sexual encounters, and certainly I don't think anybody was having sexual encounters with their guinea pigs, so or their prairie dogs, excuse me. So the point is that it can be transmitted among families, it can be transmitted among close colleagues, all those other older described means of transmission can certainly occur as well. The other thing that's important is to recognize that there are frequent co-infections with other STIs, other sexually transmitted infections, including HIV. So the presence of a known other rash should not stop you from worrying about monkeypox. So here's a few more other pictures that are showing different lesions. You can see how small that one on the hand is in the middle right, and how easily that might be confused for something else. And you can also see genital lesions there at a later stage of development where they're starting to scab up but haven't yet. But here's the other thing. There's a lot of close mimics of monkeypox. So herpes simplex, somebody could look and one, either think it's monkeypox or, more concerningly, not think that it could possibly be monkeypox. Varicella or chickenpox could be confused, especially as not that many clinicians have actually seen chickenpox anymore since we started vaccinating against it a number of decades ago. Lymphogranuloma venereum, another sexually transmitted disease that can occur in the rectal area or perirectal area. Primary syphilis, the classic chancre. Condyloma lata, which is from secondary syphilis, and molluscum contagiosum, which can look like a smallpox lesion. Chickenpox here, though, I mean, that could potentially be a little tough for somebody that wasn't used to seeing chickenpox, and a very severe case of disseminated chickenpox, as is demonstrated in the unfortunate young lady shown there, can be very confusing, especially if seen by somebody who hasn't seen either monkeypox or chickenpox before. Secondary syphilis is one of the other ones. So when we talk about lesions that appear on the palms and the soles of the feet, there's the main thing that comes to mind for an infectious disease doctor is syphilis, and but monkeypox can do this as well. Here's a few more pictures of monkeypox in the United States, and if you're interested in seeing more of that, I'll show you the websites where you can find those, thanks to CDC and IDSA, who've been producing webinars and putting guides and clinical information online. So this issue that I mentioned of being sure to test people, even if you think you know what they've got, is important. And it's also in conjunction with the fact that relatively early on in this outbreak, the guidance that was initially put out led to some barriers occurring when a provider would call for permission to submit a specimen, because that's how it works. I'll get back to that in a moment, and when we talk about collecting a specimen, that going through their state health department or their local health department, the criteria for submitting a specimen was tight enough that certain very suggestive lesions or persons with an epidemiologic history that made it concerning were not getting the opportunity to be tested, even though the testing capacity existed. So in the middle of June, this came out, this health network, to really try to emphasize to people that if somebody's got an epidemiologic risk factor, if they have any kind of a rash, even if you think it looks more like something else, you should very carefully consider testing them and go ahead and do that. So here's the updated case definitions for epidemiological and reporting purposes, as well as criteria for helping to decide who you want to test. Cases that have a significant characteristic rash or meet a epidemiological criteria and there's clinical suspicion for monkeypox ought to be tested. And that gives you the definition of your epidemiologic classifications as well. And all that's available on the CDC website. So in the US, for the most part, all cases, now granted I made this slide a couple weeks ago, but I think it's still pretty much the same, all have had a rash somewhere, but you may have to go look for it. It often is beginning in mucosal areas, and that can include genital areas or the mouth. It can be scattered, as I mentioned, like one pock up on your shoulder and another pock on your leg, or a couple of genital lesions and a couple of facial lesions. Interestingly, they can be in different stages of progression. In other words, some that are seen early in their development and some appear later at the same time. They are small, They can be painful, they can be itchy, they can be rubbery, they can be umbilicated. They may not appear on the face or extremities, which is where we usually think of as the first place they're going to be. Proctitis is almost always associated with perianal lesions if you look, but there may not always be a prodrome. There's not always that lymphadenopathy that was considered a sort of hallmark of monkeypox, and lots of co-infections. So what does that mean for a clinician? Is that a very careful examination all over the patient is essential, and to have a really low threshold to test, even if other sexually transmitted infections are known to be present. So what about laboratory diagnosis? So this is a little tricky. Right now, the way that testing is done, for the most part, is that a sample is collected, and there's some tricky things about collecting the samples. There's a lovely video from netech.org if you want to see good instruction on how to collect your specimens, but they basically are all going to come from a lesion. They can be a lesion at any stage of development. You do not have to puncture something and get the fluid. You just need to rub over it. Now, you need to know which lab your specimen is going to, or if you are a clinician, get instruction from the lab that you submit to about how it should be whether it needs to go into culture media or not, specifically viral culture media and so on. And then the sample is going to go to the state, local, regional network lab, which will identify this as an orthopox and then get sent on to the CDC to confirm that it is monkeypox. So this was a bit of the hold up earlier on, that one had to actually call your local health department and say, I've got a patient who's got this, I want to get them tested, and they had to give permission for testing to be performed. That is changing, but you have to check with your local health authority to figure out at what stage they are. CDC is starting to say on their website, you don't need to get permission, but many states or local health authorities are still wanting you to call first before submitting a specimen. When collecting the specimen, you've got to use appropriate personal protective equipment, and that means eye protection, mask, and gown and gloves, and send everything through the state or your local laboratory. So it's plenty of testing capacity, but a fairly cumbersome process. However, there is work going on now to expand options, and there are 5 commercial labs that are now also offering monkeypox testing. You need to check through your own region about whether that can be sent that way, and also make sure that there is an appropriate way to report positive results to your local health authority, because remember, this disease has to be reported if there's a positive. Now, in terms of therapeutic options, most cases we're saying are really only requiring supportive care if they're relatively mild. But if you've got someone who's at risk for severe disease, then you would want to start therapy early. So that's someone immune compromised. That would include somebody with HIV, for example, who's not under good control, pediatrics and pregnant individuals. Persons with HIV whose disease is under excellent control do not seem to be having more severe disease than persons not living with HIV. So that's important to recognize as well. But severe disease, what's severe disease? Well, it might be bad disease in the genital area. Some of these individuals are having really significant problems due to that nature of the lesions that occur there, and oral lesions as well. So what have we got? We have a medication fondly known as TPOXX, which is tecovirimat. This is an antiviral, and that's really the first line. However, you have to get it through the CDC. You can get oral or IV formulations. It can be dosed for adult or pediatrics, but you need to contact the CDC through your health department, and they will very quickly do a turnaround, affirm that it sounds like somebody who needs to be treated, and send you out the doses from the Strategic National Stockpile. But again, a little bit clunky. It's not like you can just call your pharmacy and ask for it, or, as I've heard happen to one person, hand somebody a prescription for it and tell them to go to Walgreens. Doesn't work that way. An old medication that many of us are familiar with from having taken care of HIV patients with cytomegalovirus is cidofovir. So that is under an expanded access investigational new drug protocol for orthopox viruses, but it's a little hard to use. It's got a lot of renal toxicity, and you have to monitor people super carefully. Brincidofovir is a relative of cidofovir without the renal toxicity. It is approved for smallpox. It's not officially approved for monkeypox, so they're also working on an expanded access IND for that, but it's not available in the strategic national stockpile yet. Then there's also Vaccinia immune globulin intravenous, which is basically prefab antibodies against Vaccinia, which was approved for people who have Vaccinia vaccine complications, which you're going to learn about in a moment. But that also is available under an expanded access IND. But mainly it's going to be TPOXX. There is also an eye drop antiviral for individuals who have ocular complications, which I didn't put on the slide. So I said all that about, okay, most people just need symptomatic care, and some of them are going to need this tecovirimat, but unfortunately, for individuals who have severe proctitis or significant oral or genital lesions, they may need a lot of care. Individuals are come to the point where they're completely unable to defecate because of the pain. It can be incredibly painful, or unable to urinate. They may need to go into the hospital and be catheterized in order to urinate. They can get severe dehydration from the diarrhea that's associated with proctitis and the difficulty in eating, and basically just severe pain. So that was actually just a few days ago, the head of the CDC sent out a clinician's letter to remind people that pain management really has to be part of your care protocol for individuals who have this. But most patients hopefully won't need too much, won't need to be admitted. They will isolate at home, and they have to do so until all scabs separate, until new skin has grown. So this takes a while. As I said, they can be sitting around waiting for all this to happen for 2 to 3 weeks, and a good chunk of that can be pretty miserable. Stay at home, avoid visitors, stay away from your pets as well as your people. Wear a mask when you're close to others. Don't share stuff, avoid sex, disinfect surfaces, kind of all the stuff that we said about COVID, only all that contact stuff really matters with monkeypox, whereas it didn't matter really as much with COVID. Meanwhile, the aerosol stuff matters less with monkeypox than it turned out to really matter with COVID. The other thing is your local health department will give you specific guidance. So patients need to be instructed to report to their local health department, who usually is going to want to ask a bunch of questions anyway about their contacts. And they're going to be contacting the contacts to discuss with those individuals how they need to be monitored. The CDC is not saying that anybody needs to quarantine if they're a contact. However, local health departments may make their own decisions about that. So what about vaccination? So as I keep mentioning, the vaccine that protects against smallpox is protective. These are vaccines that are based on Vaccinia virus, which was cowpox. And those vaccines were, in terms of global use, were halted with the elimination of smallpox in 1980. In the United States, routine smallpox vaccination ceased in 1972. The vaccine being used during that time was Dryvax, and it's been replaced by one called ACAM 2000, which works exactly the same as Dryvax. There's also a newer vaccine available called Jynneos, which is also based on Vaccinia virus and approved for both monkeypox and smallpox. Both are available for pre and post-exposure options, but as you'll see, from a clinical standpoint, there is the potential for preference for Jynneos. For clinicians who potentially might see a case, vaccination is not being recommended at that time, but as supply improves, that may be expanded. So primarily, these are being offered to individuals with high-risk lab work, persons who are administering ACAM, and then post-exposure, of course, as well. It's indicated. In some parts of the country, as many of you will have heard, the local health authority has expanded the eligibility to include individuals who are at high risk of contact because they are in networks that do have frequent sexual contacts. So what about ACAM 2000? So this is a live Vaccinia vaccine, again, almost exactly like the one that was used to vaccinate up through 1972. Available from the CDC, it's expanded access IND for post-exposure. It's delivered with this cute little thing called a bifurcated needle, which is a very tiny needle with 2 prongs on it to deliver a tiny amount of the vaccine just under the surface of the skin. It needs to get poked into the skin just enough to get through and see a minute spot of blood, but not all the way through the skin. Unfortunately, there's a lot of side effects and contraindications, but here's how it's delivered with that nice bifurcated needle. And there you go. Now, the side effects and contraindications derive from the fact that this is a live virus and has the capacity to replicate in humans and potentially cause either disseminated disease or severe local disease. And so, so you can see somebody in this who's accidentally transferred their vaccine into their eye. Now, I should point out, why does it transfer into their eye? Because a pock develops at the site of inoculation, and that's the one that results in a scar. So if somebody's got a scar on their shoulder, it can be from smallpox vaccine or it can be from BCG. But at any rate, so this pock that then develops can have has live virus, which then can be transmitted to other parts of the body or to other people. And if it's transmitted to someone who has certain types of skin disease or immune compromise, it can result in a very severe either localized or disseminated infection. When we were worried about smallpox, the risk of this was so low in comparison to smallpox risk that it was worth it. A little different calculation now that we have another vaccine and that the risks are a little bit lower for most people. So what's this other vaccine? This is the trade name in the US is Jynneos. It is a live vaccine, but it doesn't replicate, so it can't grow in humans and it can't cause disseminated or extended disease. And this is also based, again, on a modified vaccinia virus. It's got a couple of different trade names in different countries. Licensed in 2019 for both smallpox and monkeypox, can be used for pre-exposure as well as post-exposure prophylaxis. And again, is going to come from the CDC via the health department. So what that means, people who are looking to be vaccinated need to go to their local health department to find out when they are eligible. It's a subcutaneous dose, 2 doses, 1 month apart. And if someone, there's a little bit of discussion back and forth, but the data supports, and my last discussion with CDC indicated that if you have had prior smallpox vaccination of any sort, including back in 1970, that a single dose of Jynneos will result in an adequate immunological response for protection. So a lot less side effects. You can't transfer it to somebody else. It doesn't make a big pock on your arm. It's delivered subcutaneously. And so for those reasons, for most individuals, it's going to be the preferred vaccine. And that is mostly what's being sent out to health departments. For vaccines and therapeutics, you have to go through the medical countermeasures unit at CDC, and the procurement process again starts with the health department. If you're a clinician, you have a patient, you go through your health department, and then it goes through to CDC, and there's an evaluation of what the needs are, goes out to Strategic National Stockpile, and delivery hopefully within 24 to 48 hours. But the big deal for individuals, especially frontline workers in the healthcare system, is really to think about the identify, isolate, and inform protocol. So be aware of what's going on, be aware of the possibility, be sure to ask an appropriate history about potential exposures. At whatever point one decides that there may be a risk of monkeypox, isolate the person in a single person room and close the door. Don't need fancy things like negative pressure air handling unless you're going to do something that might cause a lot of droplets and aerosols to be created. Appropriate personal protection equipment should be used: gown, gloves, eye protection, and an N95 or better mask. Anybody that's been doing clinical care in the world of COVID is pretty used to using that kind of protection, because that's exactly the same that we do. But in this case, it's until all lesions have sloughed off. And then the final important thing is to inform your local health authority. And in Texas, that means it may be your county or whatever is the local health authority that's over your region. And from then it goes to the state and CDC. So what else a little bit about that sexual transmission? What kind of data we're getting? Well, just there's some early data still coming out, mostly from countries in Europe, that have actually found evidence of at least the DNA of the virus in semen and in stool, and in fact now in saliva and other samples. And so what does that mean? It's that live virus, and so you get increased carriage in the male reproductive system or something like that, as we worry about with some other diseases. We know that there's congenital transmission can occur, and we know that oral lesions, individuals who have oral lesions, of course, are going to be more likely to be able to have droplets that have virus in them. So that's a concern, and of course, people put their oral cavities together. It's called kissing, and so that's easy transmission there. What about the male reproductive system? So we know from Ebola that the male reproductive system can actually harbor some of these viruses long after the individual has become asymptomatic. So for that reason, there's recommendations to use a condom after recovery, but how long is really unclear. And CDC is still hedging their bets on that and just telling people on the webpage that some countries recommend using 8 weeks. Well, what do you do? 8 weeks is a long time for no sex, right? And social gatherings, what can you do? Well, the real, so CDC has a web page discussing social gatherings in particular, discussing sexual activity. And it's basically be aware of what's going on with you, be aware of what's going on with your partner, limit your number of partners, and try to have sex without touching anybody. And there's a few suggestions on the website that are sort of entertaining. You can go and peruse those. But it's really, it's a difficult question with this disease and the length of time that it takes to become non-infectious. Okay, I said we were going to come back to those cute little critters, right? So we know, as has been mentioned, that you can get monkeypox from your pets. Can you give monkeypox to your pets? Well, that's a real concern. So I've got the emblem there, a representation for One Health. And for those that are sort of getting into this One Health concept, it's the real recognition that individuals who worry about human health also have to worry about animal and environmental health and the interplay between those. So we know a number of different types of rodents can be infected. So we know chinchillas, if you've got a pet chinchilla, for sure, besides those giant rats and prairie dogs and so on. Squirrels can be infected, possibly mice and rats. And then we don't know about some other favored pets, such as gerbils, guinea pigs, and hamsters, and so on. But one can imagine the concern of establishing an animal reservoir in the United States, not necessarily with your pets, but perhaps with your vermin if, unfortunately, rats or mice that are household pests end up in contact with infectious material. And so that is a real concern. The more people that you have infected who are stuck at home for a long time, the more chance that you're going to have somebody who's in a dwelling place where there is a risk of rodents becoming infected and then going out and creating a larger burden of zoonotic disease in a rodent population. Dogs and cats, not really known that they can be infected with monkeypox. That has not been seen. At least they're a little bit different than the more typical rodents that we think about. But they can be infected with other orthopox viruses, so can't quite be ruled out yet. So a lot of this information is available from other sources, especially, of course, through the CDC and WHO, but also from a number of really excellent webinars that have been produced by CDC, either independently or with the IDSA. There's an IDEA, that's the Infectious Disease Society of America. They also have a web page, and also NETEC, which is the organization that supports those of us who have biocontainment units for the care of individuals with special pathogens. And they're the source of that nice little video about how to collect your specimens that I mentioned earlier. So I'm happy to take any questions at this point, and I can figure out how to pull up the chat.
I'm happy to read them to you from the chat. And
All
while
right.
I bring them up, I'm going to take advantage of being the moderator by asking a question myself. Because vaccine is in short supply, I think most health departments are recommending that people get one dose, saving those second doses so two people can be immunized. Is there any evidence whether one dose will protect you?
Well, so if you look at the numbers in terms of the measures of immunity that were used to have Jynneos approved, it was compared with ACAM. And what they looked at, if I remember it all correctly, was 2 weeks and then 6 weeks, because at 4 weeks is when you get another dose. And you definitely get a really nice response at 2 weeks that is tailing down if you don't get a second dose at 6 weeks. But if you get that second dose at 4 weeks, it goes up. Now, what I don't know about what you said, I hadn't actually heard anything specific about that, is whether what they're saying is they're not going to reserve that second dose at the current time, or are they in fact telling people that when you come up to 4 weeks, don't come in until we tell you? I hadn't heard anything about that from our health department, and perhaps you have more specifics about what that guidance is.
Yeah, well, it may depend on the health department as
I'm sure it
well.
does, yeah.
But because vaccine is in short supply, even if you're not telling people not to get that second dose by 4 weeks, I mean, we hear stories about, you have, just like in the early days of COVID vaccine, you had to be within, 15 seconds of the appointments opening up.
Absolutely.
Yeah. All right. So I think you answered this question, but if you got smallpox vaccination as a kid, no matter when it was, will you have some residual antibodies to give you some immunity?
I didn't precisely answer that question, and I'm glad you brought it up. So those individuals who were involved in the the monkeypox outbreak of 2003, it was clear that those who had been previously immunized had reduced chance of either getting disease or getting significant disease. So yes, we know that there is some degree of protection even before you get boosted with Jynneos, for example, which, as I said, the guidance is, I don't think it's printed out anywhere that I've seen, but single dose should be good as opposed to needing to get 2 doses in a row. And of course, if you get boosted with ACAM, that would work as well. So the answer is yes, there is some protection. It is not, however, complete immunity 100%.
Okay. A question. Monkeypox was discovered in 58 when 2 outbreaks of a pox-like disease occurred in colonies of monkeys kept for research. Is that correct?
Yes, I think I mentioned that at the beginning. They were in Denmark. Yeah.
Okay. Let me see. Infection with monkeypox virus begins with an incubation period where the person does not have any symptoms and may feel fine. Incubation period 1 to 2 weeks. A person is not contagious during this period. Is that correct?
Okay.
Are you contagious before the rash appears?
Little tricky business here. What if you don't know you've got a rash? Okay.
Yeah.
And that is, I think, the real problem. So there is, and I think it was CDC did reported that a sort of overview of cases that looked at exposure to recognition of some symptoms, even if it was not necessarily presentation to care, hitting about the 8 to 9 days mark. Okay. But what I'm going to say is, yes, some people will have an oral lesion and think they just got a canker sore or something, not recognize it as monkeypox, or will have a genital lesion or two that they can't see and not be aware that they have it. So when we say symptomatic, that may not mean recognizing that you have it. Remember, a lot of people are not reporting a prodrome before the rash is evident. And so that is why we talk about the fact that there's probably been some sort of underwater transmission going around among individuals who don't recognize that they have it because they have such a mild rash or whatever that they don't either don't notice it at all or don't think it's anything consequential.
And a couple of questions about transmission. One is about airborne transmission. I mean, you talked about droplets, but at first with COVID, we thought it was droplets only, and then it became clear that it was aerosol as well. Another question about probability of infection being spread by barber, cosmetology, massage, or something like trying on clothes at a department store.
Well, you can, on those last contact things, I'd say keep MRSA in mind, okay? That's why your barbers are supposed to be dropping all of their equipment into sterilizing solutions in between patients. HIV, for example. So yes, absolutely it could be if individuals are not using basic good contact precautions, and if they're doing something like razoring you, then bloodborne precautions, which is absolutely what they're supposed to be doing for a multitude of other diseases anyway. The aerosol thing's a little tricky, okay? One thing that tells us, and also I should say, great contrast with COVID, that this is not a disease that spreads easily by the aerosol route, is the epidemiology that we are seeing. If it were spread easily by the aerosol route, you would see lots of people getting infected on the bus, in a restaurant, at crowds where they were not engaging in close contact with other individuals. And although there may be some cases that are reporting not having any kind of close contact with anybody, the truth is the vast majority of cases, there is an epidemiologic link, even if the individual has not been identified who is their contact. So I think that's telling us something.
Right. And what about trying on clothes? I've had questions about, with school starting and kids sharing items.
Don't try on underwear and bathing suits, maybe. But I mean, that's a biggie. Nope, can't tell you a thing. They are not going to go toss into the dry cleaner every piece of clothing that somebody tries on. But once again, we are not hearing about that kind of transmission. We are not having a lot of people present with lesions who have shopping as their transmission risk. So I'm not saying it cannot happen. There's always the possibility that it could happen, but it's clearly not a major means of transmission.
And a question about lab work. Is the vaccine required for all similarly to performing rabies work? And does 10% bleach work for 10% bleach and autoclaving work for inactivation?
I am, not being the biosafety expert, going to say, yeah, I think it should, but I won't swear to nothing. Look up on appropriate biosafety pages exactly what percentage of bleach you need, but that should be fine, I would think. But again, I refuse to be the authoritative source for that. In terms of requirements for laboratory workers, yes, it is recommended that any individual working in a research lab with monkeypox, with live virus, culturing virus, concentrating virus, any of those kinds of things, be immunized with either ACAM or Jynneos vaccine. For individuals who are working in routine clinical laboratories, it is not currently recommended, nor for those who simply are handling a package that is then going to be sent off to the LRN lab or the CDC lab. If you're in the LRN lab doing that kind of work where you are actually doing the testing of the material, yes, it's recommended.
And I can say it's an envelope virus, so 10% bleach should be good for,
thank you.
Yeah, decontamination. Question about whether you think the vaccine will be recommended for the entire population, because WHO has declared and 2 states have declared a public health emergency.
Let's put it this way, only if we have lots of production and it's cheap. But so my guess is no. And again, it is because the means of transmission are not so incredibly affecting everybody. Okay, COVID, everybody's got to breathe, right? But not everybody is having lots of close contact with multiple different people who have high risk factors for getting monkeypox. So if it is eventually recommended across the board, it won't be soon. I don't think. But again, I am postulating there.
Your crystal ball is not perfect, right? How about testing individuals who feel they're at risk, may not have symptoms, but want to be tested?
We currently do not have an effective test for that. Remember, the test that we are currently using is swabbing lesions. So if you haven't got a lesion, at the very least, for example, if somebody presents, say, with proctitis and you really can't find a lesion, I would do a perirectal swab on that individual, for example. But we do not have a blood test currently.
Okay, and we're at time, so I'm going to end, but there's a lot of thank yous in there and great presentation. And I want to thank you so much for this very timely topic. Let's hope it goes away. That we're not still talking about this, but who knows?
Hope is not our primary public health response, of course. In fact, I would say extreme cynicism should be our best public health response. But yes, one can hope on the broader scale.
All right. Well, again, lots of kudos. And I was going to say also, as a non-clinician, I really appreciated your dumbing down some of the terms for us. So you made it very clear. Thank you. Stay tuned next month. We'll be sending out about the adenovirus and hepatitis as soon as we get the date set. If you have suggestions for future topics you'd like to have a grand rounds on, I'm trying to think how you can contact me. I think we'll put something on the website where you can put in suggestions, or you can email me. But I can put it in the chat. It's just a hard email, a long email. All right, there, it's in the chat. So let me know any comments, suggestions. And thank you, everybody. Thank you so much, Dr. McLellan.
Thank you so much for inviting me.